You are listening to part 89 of our series, 7 Medicines, The Wise Woman Way, with Susun Weed at Time Monk Radio. Hello, Susan, and welcome back to Time Monk Radio.
Hi, Gemini. It's good to be back with you after everybody's busy summer to slide into some cooler weather and to face some difficult things. We've gotten deep into high-tech medicine. We've gotten deep into modern medicine, and nowhere is medicine more modern than when it comes to surgery. Surgery's been with us for thousands and thousands of years, and that included necessary surgeries like amputations and elective surgeries like trepanning, where holes were drilled into people's skulls in order to awaken and enlighten them. But what characterized all of that surgery for all of those thousands of years was there basically wasn't any anesthesia. So in our next series of shows, we're going to be looking at surgery, and we're going to be looking at anesthesia, because that's what really makes surgery. Today, that's what makes it possible, is that we can operate on people who, to the best of our knowledge, aren't feeling what is happening. Now, we'll talk about whether or not that's true, but at least it gives the surgeon that sure sense. Now, I personally don't do really well with anesthesias of any kind. And so when the dentist wants to do something, there's always this kind of, he looks at me or she looks at me, and I look at her or I look at him, and I say, no, you're not going to shoot me up with anything. You're just going to do this. And you can see them, I think, I should bring herbal remedies to help the dentists, because they lose a little blood from their face. And I say, look, what I want you to do is look at my hand, because we know that if I'm in pain, my hand is going to involuntarily tighten up. And you can keep track of my hand, and if my hand looks relaxed, then you know I'm relaxed and you're not hurting me. But there's not a lot of people who have that kind of mental control over the pain that they're experiencing. So we're going to talk about what kind of anesthesias are available, who does them, how that is going to have impact on you if you need or if you choose to have surgery. So what is the very first thing that we need to do if we're going to have surgery? The first thing that we need to do if we're going to have surgery is make sure that we really, really need that surgery. You could ask the surgeon or the doctor who's recommending that you have surgery questions like, what will be my benefit as a result of this surgery? And if the answer is you'll feel better or your mind will be more at ease, understand that those are not real answers. You need to have a real explanation. So I have seen people who have had their knees replaced, and the vast majority of those people are extremely happy with their knee replacements. But there are a few who aren't. And the few who aren't really thought that if they got their knee replaced, that not only would they be out of pain, but the new knee would function the same as though they had a regular knee but brand new. And of course, that's not true. And so they didn't really understand what they were going to get from the surgery. Really take the time you need. Don't just look on the internet, get some books, talk to people. No, don't just talk to one surgeon, talk to several surgeons. I was quite amazed. I had a friend who had a horrible accident, and she was rushed to the hospital and taken into surgery, and I arrived about 24 hours later. And I asked the nurses, were any of you present at surgery? Yes, I was at this nurse. I said, could you tell me what happened? And she told me what happened. And then later on, there's a different nurse, and I said, do you know anything about the surgery? Yes, I was present. Tell me what happened. And she told me a different story. I mean, different as to what they did and which bone they did it to. Different story. And these were two people who were right there. So beforehand, really get the goods. I was with my uncle in the hospital, and he was having a heart valve replaced. And I was there with my cousin and my aunt, as well as my uncle. And he was being checked into the hospital for the valve replacement. And we were all there with him. And the angel who was checking us in said, we have a movie showing you this surgery so you will know exactly what happens. Would you like to see it? And my uncle, who's getting the surgery, said, oh, absolutely not. That's the last thing I want to see. Then my cousin and my aunt and I said, yes. And they took us into another room, and they actually showed us a video that they had taken during the replacement surgery. And, of course, it had been edited and had all other things that said, you know, you have these choices and so on and so forth. And I was very suitably impressed. I would have preferred to have seen that movie, or to have my uncle see that movie if he was in the mood for it, well before he had agreed to the surgery. But I was nonetheless impressed that at least it was available. Ask what the risks are. Most surgeons downplay the risks of surgery. The few surgeons who've really spoken from the shoulder and off the cuff to me have really opened my eyes to how every day surgery is to a surgeon, but how it might be once in a lifetime to us. And so a risk that happens 1 in 1,000 times is practically nothing to a surgeon, but that risk that happens 1 in 1,000 times, to me, I might be that 1,000th one. Many of us remember reading in the newspaper about Joan Rivers, who went in for an outpatient procedure and who died as a result of her airway collapsing. Had she asked what the risks are, and had she been told that there's a risk that your airway could collapse and then you won't be able to breathe and you'll die, then she might have said, do you have, at the facility, the outpatient facility where this surgery is going to be done, do you have the capability to treat me if this risk occurs? Even if it's a risk that doesn't happen very often, it's still important to know that that risk can happen and whether or not you would be able to be treated for it. Most outpatient surgical centers are equipped with a crash cart, which is used for cardiac emergencies, and specialized drugs like dantrolene and succinylcholine. Dantrolene reverses a rare but deadly complication from anesthesia called malignant hyperthermia. We all know about hypothermia, which is a very low temperature, but hyperthermia is very, very high temperature. So that drug is always stocked in hospitals, but it's not always in outpatient centers. It would be a good idea to make sure some is on hand. It's a rare, but it's deadly. And the other one, that long succinylcholine, is a fast-acting paralytic agent. And you're thinking, well, why would we want a fast-acting paralytic agent? So that we can intubate you. If this drug had been on hand when Joan Rivers' airway collapsed, they could have given it to her, intubated her, and she would be alive today. So it's a good thing to ask about, and you can either ask about it specifically in terms of, do you have a card? Do you have these drugs? Or you can ask about it in general, are you prepared not only for the general common risks during surgery, but for the very rare ones as well? Can this surgery make my problem worse? I know, this seems like a kind of like, what? Well, I certainly wouldn't choose surgery if it made my problem worse. Right, we certainly wouldn't. So it's worth asking. In a study done 2 years ago, 31 people had their knees operated on to repair tears in the cartilage that stabilizes the knee joint. And all 31 of them developed arthritis in that joint within 1 year, compared to only 59% of 165 people with knees that hurt just as badly that did not have surgery. Everyone who had surgery as a consequence developed arthritis in the joint that was operated on. Only 59% of those who avoided surgery wound up with arthritis. Those sound like pretty good odds to me. And again, I had experience where I, in Costa Rica, broke my wrist. It was some months later when it was x-rayed back in the United States, because I was working with a physical therapist who wanted to have an x-ray. The attending a person who came to discuss the x-ray results with me said, well, it's not healed evenly. This, you can see here that it's, the bone, like where it was broken, it just healed a little bit tilted. He said, so that's, of course, a spot where arthritis could develop. And so what we're going to suggest that you do is have surgery. We'll re-break the bone, and we'll set it better, and we'll pin it and screw it together. And when I ran this suggestion past the physical therapist, she looked at me and she said, are you crazy? I said, you aren't either. She said, right, you have surgery, you're guaranteed to have arthritis. You don't have surgery, you have about a 60-40 chance of arthritis. I said, I'll take it, because I know that I'm proactive. I'm going to be working with my wrist. That's why I'm here doing physical therapy with you, and I'm going to keep on doing it to avoid that. How much energy are you willing to put into your healing? I was very surprised to read Andrew Weil's 10 steps to successful surgery, and to hear him say, a growing body of research indicates that patients who take an active role in preparing for surgery heal faster, have less postoperative pain, less need for medication, shorter hospital stays, and in some instances, avoid surgery altogether. Yes, indeed, the right pre-operative questions and exercises may make that surgery something you don't really need or want after all. Now, the joint surgery and the arthritis, and the broken wrist and the arthritis, those are kind of common things, and it's pretty easy to imagine yourself, kind of getting through that with your wits about you. But there are other things that are much, much scarier, and we can be frightened into doing surgery that we don't really need. During a routine exam, a woman was told that her carotid arteries were obstructed with plaque, and that she needed to have an operation immediately. In fact, when she hesitated, the doctor said, no, you don't understand. You have to schedule your appointment for as soon as possible, or you're going to have a stroke and die. Well, at the time, she felt fine. But the doctor gave her the impression that the surgery would be quick and very, very simple, and it wouldn't be traumatic at all. So, given that she was being told she could die if she didn't have it, she agreed to the surgery. When she awoke, she couldn't move her left side. She couldn't tell what time it was when she looked at the clock. She was paralyzed. She had had a stroke during the surgery. About 4 to 5% of middle-aged and older adults will have some carotid blockage, which is often called carotid stenosis. And every year, about 100,000, 150,000 people are going to have surgery because of their carotid stenosis. Some have the surgery that's being talked about in this article, and others have a stent placed. Certainly stroke is something that should concern everyone middle-aged and older. It's one of the most common causes of death and disability in the United States, affecting almost 1 million people a year. But only 20% of those strokes come about from a blockage in a large artery like the carotid. In other words, 20% are not coming from the carotid, but from clots in large arteries. In fact, usually strokes come about from clots in much smaller arteries. The vast majority of people with a blocked carotid artery will die with it, not because of it. Journal of the American Medical Association, Neurology, followed almost 4,000 heart patients for 25 years. During that time, a little less than 10%, a little over 300 people developed carotid disease, and of those, only one had a stroke during that period. Clearing out a clogged carotid artery is starting to look like an operation in search of a problem during or after the procedure. Bits of plaque can break free and lodge in the small vessels of the brain, and that's what triggers the stroke. In other words, the plaque in the carotid, it's a large enough blood vessel, it's not really that dangerous, and certainly doesn't need immediate surgery. But once you go in there and you do the surgery, you disturb the plaque can flake off, a little bit of it can get out and can block up a minor blood vessel, and those are the ones that, when they get blocked, really cause the stroke. If she had said to the doctor, "Could the surgery you're suggesting hurt me?" the doctor should have said to her, "Yes, it could hurt you." But we are given to believe that she was frightened. We don't think well when we're frightened, and it's also one of the reasons that I say to people, don't agree to any surgery until you've had some time to think about it. Depending on where you have the procedure done, the risk is going to be greater or lower. The Journal of American Cardiology looked at the surgery outcomes of stenting a carotid artery in about 200 different hospitals, and the risk of a stroke ranged from 0 in some hospitals to 19% in other hospitals. It makes a difference. In fact, what the article concluded was drugs that lower cholesterol, a person's own ability to keep a healthy weight, and a person's ability or drugs to control blood pressure are so powerful that if a person has carotid stenosis and no symptoms, they are better off leaving the plaque in the carotid completely alone. At this point, about 90% of the patients in the United States who are undergoing surgery or stenting in their carotid have never had any symptoms. And we could probably rightly say that this surgery was not only completely unnecessary for them, but increased their risk of death and disability. We're in high-tech medicine. The stakes are high here. A professional medical meeting had a session called Carotid Artery Stents, Ill-Advised, Malpractice, or Criminal? Wow, I don't like the sound of any of those. So I'm simply using this as a case in point. If something that seems so clear-cut, your carotid artery is blocked and you could have a stroke, let us clean it out. If that is literally not true, what else are you being told that isn't true? Ask these questions of your surgeon or the doctor who is recommending the surgery. Do some digging. If you don't feel like doing the digging yourself, hire somebody to do it for you. If I want to research a particular topic and I don't have the time, or I feel like I'm not really a good enough at searching, I hire somebody who is a search expert, and I say, search this for me. For instance, I said, search for me the use of enzymes in fruits and vegetables and how they impact the human body. And the answer that I got was quite amazing, and that is that basically enzymes in fruits and vegetables have no function whatsoever in the human body. I was glad she did that research. In 2014, the U.S. Preventive Services Task Force advised against routine carotid artery screening. Nonetheless, such tests are still done very, very often. In the past 5 years, there's been a 27% increase on this kind of surgery being paid for by Medicare. And the Journal of the American Medical Association Internal Medicine named carotid screening as the most overused procedure currently. Doctors check for carotid blockage without any reason at all. Health fairs often offer free tests. This reminds me very much of when I was a child and you walk out of the supermarket and there would be a big trailer parked out there and there would be free chest x-rays and everybody lined up and went in and exposed themselves to hard radiation because we were curious. Curiosity killed the cat, but the cat has 9 lives. We don't. So don't have your carotid artery screened unless you have a reason. And if there's a reason, and if your doctor finds plaque, then go for medical management, including statins, exercise, weight loss, blood pressure control. If you do decide to choose a procedure, get a second opinion, and then get a third opinion, and not from the same healthcare specialist. One recent study found that neurologists and stroke specialists were far less enthusiastic about surgery than cardiologists and surgeons. It's been said, and it's certainly true, that to the surgeon, everything seems to be curable by surgery. But maybe that's not the best choice for your health. Wow. What's the first thing we're going to do if we're considering surgery? We're going to ask some questions. We're going to say, how am I going to benefit from this? What are my risks? I want to know all the risks, even the ones that don't come about very often. Can it make my problem worse? What do medical professionals other than surgeons have to say about this? And what are the alternatives? There are a great many practitioners of different kinds of medicine. Medicine from China is a really excellent kind of medicine. It is not based on the same tenets as Western medicine, but neither does it throw Western medicine under the bus and say, we're not going to do this. No. Chinese practitioners tend to be some of the most integrative healthcare professionals that I know. I have been mentioning all year long something that really got my interest, which is that it's considered malpractice in China to give someone chemotherapy without giving them an adaptogenic herb that will counter the bad effects of the chemotherapy at the same time. Contrast that to what goes on in American hospitals, where if they give you chemotherapy, they say, don't take any herbs, don't even drink mint tea, who knows how it will interact. We do know. Our doctors may not know, but we know. There's thousands of years of evidence. So check into the alternatives that you could use perhaps to not have that surgery, or alternatives that you could use to help you get through that surgery. And that is what we are going to be talking about on our next show, is getting through the surgery as well as some alternative things. And one last question. What do you think will happen if I refuse this surgery? You might be surprised at the answer that you get. Well, actually, it's not the last question. It's just the last in my list of questions, because I start a whole other list with be clear about the costs. So this is a little more than just how much will it cost, because nobody's going to be able to tell you how much it will cost, because it's divvied up into a great many pockets. You, of course, are going to pick a surgeon that's in your health insurance network, because you want that surgeon to be paid for by your insurance. And you've probably chosen your doctor as someone who's in your network, and so you think everything is going to be fine. However, the anesthesiologist, the surgical staff, the pathologist, if one is involved, and radiologist, if x-rays are involved before or during the surgery, may not be in your group, and they can bill you separately, and you're stuck for it. You can ask your surgeon to make sure that everyone involved is in your network. This is within the realm of what you can ask for when you're talking to the surgeon and laying out what you want. I know it's really easy to think, why should I be proactive about surgery? Again, as Andrew Weil puts it, you're going to be immobilized, anesthetized, and traumatized. Most people think there's not a thing I can do about it. There's a lot you can do about it. And getting clear on really what it's going to cost, believe me, is going to be extremely important post-operatively as those bills come in from here, there, and the other place. If you are already stuck with a bill from an out-of-network biller, please go to CR.org/ and the lower part of the slash is on the left and the upper part of the slash is on the right. Surprise Me Bills. That's C, R for Consumer Reports, .org. And I don't know if it's front or backslash, but it's going from the left to the right. Surprise Me Bills. And they will help you work it out. There are laws being passed in states to prevent this kind of, oh my gosh. And one last thing, to investigate your surgeon. Does she or he have recent and significant experience? What are their complication rates? You don't have to go with the person your doctor recommends. You have choices. Well, that's it for this week. Lots more to talk about in coming sessions. Thanks so much for giving me this space, Gemini.
Thank you, Susan. And this concludes part 89 of our series, The 7 Medicines, The Wise Woman Way with Susan Wade at Time Monk Radio.